Clinic case study in the Cath lab. Clinical case study in the Cath lab. Patient history involved a 64-year-old male with a history of methamphetamine use, diabetes type 2, hypertension, hyperlipidemia, chronic hypoxic respiratory failure on HOMO2, coronary artery disease status post left circumflex artery stent with a stent thrombosis, combined systolic and diastolic heart failure due to ischemic cardiomyopathy with ejection fraction of 10%, status post implantable cardioverter defibrillator present, and arterial fibrillation on apixaban. Patient states having a non-radiating substernal pressure-like chest pain while sitting and eating. Chest pain is associated with shortness of breath, nausea, dizziness, and lightheadedness. Nitroglycerin was given for that pain. He said that the pain was about a 15 out of 10. Denies orthopnea, unable to sleep due to back pain, endorses lower extremity edema. Patient was not taking meds for the last 2 days. Patient went to urgent care 3 days before admission for dysuria or painful or difficult urination. UTI given ciprofloxacin. Currently denies dysuria. During admission, he was given vitals of a temperature of 98.4, a heart rate of 109 to 127, blood pressure 102 to 133, over 69 to 82, respiratory rate of 19 to 23, SpO2 determined at 98 to 100% on room air. ECG showed an atrial fibrillation with a heart rate of 113 and incomplete left bundle bunch block. Normal initial troponin and CKMB. There was significant hyponatremia of 131, hypochloremia of 85, hypokalemia of 2.9. There was an acute kidney injury with creatine of 1.7, a pro-BNP of 4,493. His last pro-BNP was 2,517 2 weeks ago, and he has an elevated total bilirubin of 1.6. The drugs he was given was nitroglycerin, indicated for the prevention of angina pectoris due to coronary artery disease. He was given aspirin, Zofran, which is to prevent the nausea and vomiting he was having. He was given metoprolol, which is for the AFib and hypertension and ejection fraction. The magnesium sulfate he was given for the replacement therapy of magnesium deficiency. Potassium chloride was also given for the treatment with patients with hypokalemia, and Norco for the chest pain. On the physical exam, the patient expressed general alert and mild distress, anxious and agitated. He had a neck jugular venous distension to the jawline, and the trachea was midline. Lungs showed that no labored breathing, equal and clear bilateral breath sounds, no wheezes, rales, or bronchi. Extremities was +2 pulses bilaterally, +2 pitting edema in bilateral extremities. Heart rate showed a tachycardia, irregular heart rhythm, normal S1 and S2, no murmurs, rubs, or gallops. Troponin showed a 0.04, total bili was 1.6, and creatine was still at 1.7. What I found interesting in the physical exam was the heart sounds. There was no murmurs to be heard, despite the report of having atrial fibrillation. In addition, the breath sounds having no crepitus, rales, or rhonchi despite having pitting edema. The fluid may or may not have been in the lungs just yet. Currently, the medications he was taking prior to the admission was apixaban, 5 milligrams, used as a blood thinner, aspirin, 81 milligrams to protect the heart, atorvastatin, 40 milligrams for cholesterol-lowering medication, bumetanide, 2 milligrams, is used for a diuretic for the congestive heart failure, metformin, 100 milligrams for the diabetes, metolazone, 2.5 milligrams for kidneys, metoprolol succinate, 25 milligrams, is a beta blocker for his fibrillation, hypertension, and ejection fraction. Potassium chloride is for electrolyte loss. Baclofen, 10 milligrams, is used for muscle spasms, patients stating having back pain. Spirolactone, 25 milligrams, is a potassium-sparing diuretic. Docusate sodium, 100 milligrams, is a stool softener. Famotidine, 20 milligrams is to prevent the stomach from GERD. Lidocaine 5% patch is used for pain, as well as the oxycodone 5 milligrams, again, is for pain. Since his admission, he is given aspirin 81 milligrams, atorvastatin 40 milligrams, heparin 4,000 units, metoprolol, succinate 25 milligrams, potassium chloride 20, spironolactone 25 milligrams, and PRN of dextrose, heparin, and insulin lispro. Indications for these medications. For aspirin, the American Diabetes Association and the AHA jointly recommend aspirin therapy of 75 to 162 milligrams for primary prevention of heart disease for persons with diabetes aged greater than 40 years or who have additional risk factors for CVD and no contraindications to aspirin therapy. American Stroke Association and the AHA further recommend aspirin for cardiovascular prophylaxis among persons whose risk is sufficiently high for the benefits to outweigh the risks associated with treatment. Torvastatin therapy is a lipid-altering agent that should be only one component of multiple risk factors intervention in individuals at significantly increased risks for atherosclerotic vascular disease due to hypercholesteremia. Indicated as an adjunct to diet for treatment of elevated total C, ApoB, and TG levels, and to increase HDL-C in patients with primary hypercholesterolemia and mixed dyslipidemia. Cardiovascular disease prevention is used for this medication as well. Reduction of the risk of stroke and heart attack in type 2 diabetes patients with evidence of heart disease but with the other cardiovascular risk factors. Patients with CHD to reduce risks of myocardial infarction, stroke, revascularization procedures, hospitalization for CHF, and angina. Heparin is an anticoagulant therapy in prophylaxis and treatment of venous thrombosis and its extension. Is a low-dose regimen for prevention of postoperative deep vein thrombosis and pulmonary embolism in patients undergoing major abdominothoracic surgery or those who are at risk of developing thromboembolic disease. Is it also a prophylaxis and treatment of pulmonary embolism, atrial fibrillation with embolization, diagnosis and treatment of acute and chronic consumptive disseminated intravascular coagulation, or DIC. It's also used for the prevention of clotting in arterial and cardiac surgery. It's also a prophylaxis and treatment of peripheral arterial embolism. Heparin may also be employed as an anticoagulant in blood transfusions, extracorporeal circulation, and dialysis procedures, and in blood samples for laboratory purposes. Metoprolol succinate is used for hypertension to lower blood pressure. Lowering blood pressure reduces the risk of fatal and non-fatal cardiovascular events, primarily strokes and myocardial infarctions, angina pectoris, heart failure, for the treatment of stable symptomatic heart failure of ischemic, hypertensive, or cardiomyopathy origin. Potassium chloride is used for the treatment of patients with hypokalemia with or without metabolic alkalosis, in digitalis intoxication, and in patients with hypokalemic familial periodic paralysis. If hypokalemia is a result of diuretic therapy, consideration should be given to the use of a lower dose of diuretic, which may be sufficient without leading to hypokalemia. It's also used for the prevention of hypokalemia in patients who would be at particular risk of hypokalemia were to develop a digitalized patients or patients with significant cardiac arrhythmias. Spironolactone is used for the management of primary hyperaldosteronism for establishing the diagnosis of primary hyperaldosteronism by therapeutic trial as a short-term preoperative treatment of patients with primary hyperaldosteronism. It's also used for patients with congestive heart failure for the management of edema and sodium retention when the patient is only partially responsive to other therapeutic measures. It is also indicated for patients with cardiovascular congestive heart failure, taking digitalis when other therapies are considered inappropriate. Mechanisms of action for this medication. Felix Hoffman proved that aspirin and other nonsteroidal anti-inflammatory drugs inhibit the activity of enzymes now called cyclooxygenase, which leads to the formulation of prostaglandins, or PGs, that cause inflammation, swelling, pain, and fever. However, by inhibiting the key enzyme in PG synthesis, the aspirin-like drug also prevented the production of psychologically important PGs, which protect the stomach mucosa from damage by hydrochloric acid, maintain kidney function, and aggregate platelets when required. Aspirin is a prototype of non-steroidal anti-inflammatory drugs and member of the family of salicylates that have in common salicylic acid as the active agent. Salicylic acid is composed of a benzene ring and two radicals, one hydroxyl and one carboxyl. In the acetylsalicylic acid or aspirin, the hydroxyl group, salicylate, is transformed into acetyl group for esterification. Atorvastatin is a synthetic lipid-lowering agent. It competitively inhibits the HMG-CoA reductase, the enzyme which catalyzes the conversion of HMG-CoA to mevanolate, a key step in cholesterol synthesis. Atorvastatin also increases the number of LDL receptors on hepatic cell surfaces to enhance uptake and catabolism of LDL and reduces LDL production and the number of LDL particles. This agent lowering plasma cholesterol and lipid protein levels and modulates immune responses to suppressing MHC2. Heparin binds to the enzyme inhibitor antithrombin 3, causing a conformational change that results in an activation through an increase in the flexibility of its reactive site loop. The activated AT then inactivates thrombin, factor XA, and other proteases. The rate of inactivation of these proteases by AT can increase by up to 100 or 1,000-fold due to binding of heparin. Heparin binds to antithrombin via a specific pentasaccharide sulfation sequence contained within the heparin polymer. Metoprolol is a cardioselective beta-1 adrenergic blocking agent used for acute myocardial infarction, heart failure, angina pectoris, and mild to moderate hypertension. At low doses, metoprolol selectively blocks cardiac beta-1 adrenergic receptors with little activity against beta-2 adrenergic receptors of the lungs and vascular smooth muscle. Receptor selectivity decreases with higher doses. Metoprolol competes with adrenergic neurotransmitters such as catecholamines for binding at beta-1 adrenergic receptors in the heart. Beta-1 receptor blockade results in a decrease in heart rate, cardiac output, and blood pressure. Supplemental potassium is in the form of high potassium food, or potassium chloride may be able to restore normal potassium levels. Potassium chloride acts as an electrolyte replenisher of potassium ions. It is used as a source of potassium cation, the major cation of the intracellular fluid, essential for maintenance of acid-base and fluid and electrolyte balance of the cell. It also plays a vital role in the conduction of nerve impulses, contraction of cardiac smooth muscle, skeletal muscles, gastric section, normal renal function, and carbohydrate metabolism. And then the potassium-sparing diuretic is a specific pharmacological antagonist of aldosterone, acting primarily through competitive binding of receptors of the aldosterone-dependent sodium-potassium exchange site in the distal convoluted renal tube. Aldostone causes increased amounts of sodium and water to be excreted, while potassium is retained. Aldostone acts as a diuretic and as an antihypertensive drug by this mechanism. It may be given alone or with other diuretic agents which act more proximally in the renal tube. Potential side effects of aspirin include the most frequently observed adverse reactions include lightheadedness, dizziness, sedation, shortness of breath, nausea, and vomiting. The most common adverse reactions associated with the use of aspirin have been gastrointestinal, gastritis, occult bleeding, constipation, and diarrhea. Atorvastatin side effects include nasopharyngitis, arthralgia, diarrhea, pain in extremity, UTI, rhabdomyolysis with renal failure, myopathy, elevated serum transaminases, increases in HbA1c, and fasting serum glucose, cognitive impairment, and necrotizing myopathy in rare immune-mediated. Potential side effects of heparin include thrombocytopenia, heparin-induced thrombocytopenia, and heparin-induced thrombocytopenia and thrombosis, local irritation, and hypersensitivity. For metoprolol succinate, one thing I found very interesting was the on-the-box label that states, following abrupt cessation of therapy with certain beta-blocking agents, exacerbations of angina pectoris and in some cases myocardial infarction have occurred. Discontinuing chronically administered metoprolol, particularly in patients with ischemic heart disease, the dosage should be gradually reduced over a period of 1 to 2 weeks, and the patient should be carefully monitored. If angina markedly worsens or acute coronary insufficiency develops, metoprolol administration should be reinstated promptly, at least temporarily, and other measures appropriate for the management of unstable angina should be taken. What I found interesting that the patient stopped taking his medication 2 days before metoprolol, before the admission, and he had exacerbation of angina and possible myocardial infarction. Adverse reactions include worsening angina or myocardial infarction, worsening heart failure, and worsening AV block. Potassium chloride side effects, one being the most severe adverse effect is hyperkalemia. There have also been reports of upper and lower gastrointestinal conditions, including obstruction, bleeding, ulceration, and perforation. The most common adverse reaction to oral potassium salts are nausea, vomiting, flatulence, abdominal pain, discomfort, and diarrhea. These symptoms are due to irritation of the gastrointestinal tract and are best managed by diluting their preparation further, taking the dose with meals, or reducing the amount taken at home. Spirulactone, one of the potential side effects in the digestive system is gastric bleeding, ulceration, gastritis, diarrhea, cramping, nausea, and vomiting. It can also be including leukopenia, thrombocytopenia, hyperkalemia, electrolyte disturbances, and thrombocytopenia. The patient then had a coronary angiography procedure. Indication for procedure or reason for admittance. Patient came in with angina, which is a chest pain caused by imbalance between oxygen supply, a decreased coronary blood flow, and oxygen demand, which is increased myocardial oxygen consumption, which leads to a decrease in the oxygen supply demand ratio in the myocardial hypoxia. The decreased flow can result from coronary artery vasospasms, fixed stenoic lesions in chronic vessel narrowing, or from a blood clot that incompletely or completely occludes a coronary artery. Oxygen consumption can be elevated in increased heart rate, contractility, inotropy, afterload, and preload. Patient went under procedure due to having a diagnosis of unstable angina, which is sometimes referred to as acute coronary syndrome, causes unexpected chest pain and usually occurs while resting. The most common cause is reduced blood flow in the heart muscle because the coronary arteries are narrowed by fatty buildup of atherosclerosis, which can rupture, causing injury to the coronary blood vessel, resulting in blood clotting, which blocks the flow of blood to the heart muscle. Unstable angina should be treated as an emergency. If there are new worsening or persistent chest discomfort, you need to go to the ER. This could be in signs of a heart attack, which puts you at risk for severe cardiac arrhythmias or cardiac arrest, which could lead to sudden death. Causes of unstable angina include blood clots that block an artery partially or totally are what causes unstable angina. Blood clots may form partially, dissolve, and later form again, and angina can occur each time a clot blocks blood flow in the artery. Coronary artery disease causes changes in both structure and function of the blood vessels. Atherosclerotic processes cause an abnormal deposition of lipids in the vessel walls, leukocyte infiltration and vascular inflammation, plaque formation, and thickening of the vessel walls. These changes lead to a narrowing of the lumen, which restricts blood flow. They are also subtle yet functionally important changes that can occur before overt changes in structure are observed. Early in the disease process, the endothelial cells that line the coronary arteries become dysfunctional. Because the endothelium produces important substances such as nitric oxide and prostacyclin that are required for normal coronary function, endothelial dysfunction can lead to coronary vasospasms, impaired relaxation, and formation of blood clots that can partially or completely occlude the vessels. When CAD restricts blood flow to the myocardium, there is an imbalance between oxygen supply and oxygen demand. When the oxygen supply is insufficient to meet the oxygen demand, the myocardium becomes hypoxic. This is often associated with chest pain like angina and other clinical symptoms. Severe ischemia can lead to anoxia and infarction of the tissue. Furthermore, acute and chronic ischemia caused by CAD can impair cardiac, mechanical, and electrical activities, leading to a heart failure and arrhythmias. Unstable angina is caused by transient formation and dissolution of a blood clot within a coronary artery. The clots often form in response to plaque rupture in atherosclerotic coronary arteries. However, the clot may also form because decreased or diseased coronary artery endothelium is unable to produce nitric oxide and prostaglandin. They inhibit platelet aggregation and clot formation. When the clot forms, coronary flow is reduced, leading to a reduction in oxygen supply-demand ratio. If the clot completely occludes the coronary artery for a sufficient period of time, the myocardium supplied by the vessel may become infarcted and become irreversibly damaged. The form of angina is treated with drugs that reduce oxygen demand, such as beta blockers, calcium channel blockers, nitrodilators. But more importantly, this is if this form of angina is treated with drugs that inhibit thrombus formation, such as antiplatelet drugs and aspirin. Angina may also be precipitated by a combination of supply and demand ischemia. For example, diseased stenoic coronary segments can sometimes undergo vasoconstriction during exercise. This probably occurs due to the absence of sufficient production of nitric oxide and perhaps prostaglandin by the vascular endothelium to counteract normal sympathetic mediated effects on the vascular alpha adrenoceptors. That a hemodynamic condition may exist that leads to coronary vascular steal. In this condition, multiple fixed stenoic lesions can lead to a redistribution of flow within the major supply arteries of the heart under conditions of exercise or vasodilator therapy. As blood flow increases in one region of the coronary vascular network, blood flow can reciprocally decrease in another region, leading to anginal pain. Cardiac-specific troponin and cardiac-specific troponin T shortly thereafter provide two closely related biomarkers that are considerably more sensitive and specific than CK&B, and therefore detected myocardial necrosis far more frequently and accurately. Picture A shows the zone of necrosing myocardium. Picture B is a diagram of the myocardial that is in the process of releasing biomarkers. After disruption of the sarcolemma of the cardiomyocyte, the cytoplasmic pool of biomarkers is released first. Serum levels rise quickly above the upper reference limit. This is followed by a more protracted release from the disintegrating actin that may continue for several days. Cardiac troponin levels rise to about 20 to 50 times the upper reference limit in patients who have a type 1 acute myocardial infarction and sustain sufficient myocardial necrosis to result in abnormal elevated levels of creatine kinase MB or CK-MB. Microinfarcts can be detected by sensitive assays that detect cardiac troponin elevations above the upper reference limit, even though CK-MB levels may still be in the normal range, which this patient showed normal CK-MB levels throughout his entire stay. In the process of coronary angiography, the doctor will inject a local anesthetic into the groin, arm, or wrist, and if the arm used, they will make a small cut. The catheter will be inserted into the main artery at that point. The catheter will be removed through the main blood vessel of the aorta to the beginning of the coronary arteries of the heart. Its progress is watched via X-rays shown on a monitor. Most people will not feel any pain or sensation during this test. Coronary angiography is defined as the radiographic visualization of the coronary vessels after injection of radiopaque contrast media. It is most commonly performed with specialized intravascular catheters. The procedure is usually included as part of cardiac catheterization, which may also involve angiography or other vascular structures such as aorta and left ventricular. The purpose of coronary angiography is to define the coronary anatomy and the degree of luminal obstruction of the coronary arteries. It is most commonly used to determine the presence and extent of obstructive coronary artery disease and to assess the feasibility and appropriateness of various forms of therapy, such as revascularization by percutaneous or surgical interventions. It is also used when the diagnosis of coronary artery disease is uncertain and coronary disease cannot be reasonably excluded by non-invasive techniques. There are no nerves inside your arteries, so you will not feel the movement of catheters through your body. When the catheter is in place, a small amount of X-ray dye will be injected into it. The X-ray will be taken as the dye travels through the coronary arteries. These X-rays will be shown on a monitor and recorded on a computer. Different catheters are needed to study the various arteries. One will be removed and the next introduced through the same place in your groin or arm. Some people have nausea or chest discomfort when the dye is injected, but this does not last long. A larger injection of dye is given in the heart muscle. If your heart muscle is to be examined, this may give warm feeling in your upper chest first, then over the rest of your body. The feeling may last for about 10 to 15 seconds, and the test will take about 30 to 40 minutes. When the test has been completed, the catheter will be removed and pressure applied to the area will be inserted. You will be moved to the ward or recovery area to bed rest for at least 4 hours. In most circumstances, you will be allowed home after 4 to 6 hours. Some people may need to stay in the hospital longer, so if their symptoms can be monitored further. The X-ray dye passes through your kidneys and excreted into your urine. After the procedure, the treatment plan for unstable angina include starting an IV heparin, continue aspirin, continue home atorvastatin, continuing metoprolol succinate, starting Renaxa, having a follow-up of cardiac enzymes times 3, daily EKG, PRN, chest pain, bed rest, pulse oximetry, and telemetry, as well as nitroglycerin, PRN. The treatment plan for the CAD status post LCX stent with in-stent thrombosis, continue aspirin and continue home atorvastatin. The treatment plan for the chronic combined diastolic and systolic heart failure, as well as moderate to severe tricuspid regurgitation and moderate mitral regurgitation, is treated with Bumex, metolazone, metoprolol succinate, spirulactone. They would suggest monitoring electrolytes, giving a 2-gram sodium diet, daily weights, strict INOs, as well as telemetry and pulse oximetry. The treatment plan for atrial fibrillation include resuming home apixaban, heparin, home metoprolol succinate, telemetry, as well as EKGs, PRN. Treatment plan for the diabetes include holding the home metformin, AccuChecks 3 times daily before food, and insulin correction scale, as well as hypoglycemic protocol. Treatment plan for acute kidney infection include a trend in the creatine, monitoring electrolytes, strict INOs, UA and UCX labs, as well as holding antibiotics pending the UNA and UCX labs.